Hello, welcome everybody to this recording and to this discussion about the case that Dr. Conte would present to you in a moment and will be commented by Dr. Lambiase. I am Angelo Auricchio, the editor-in-chief of Arrhythmia Academy, a new web platform supported by Radcliffe. I'm very, very honored to have one of my associates, Dr. Conte, at Cardiocentro Ticino, and even more, very happy to see Dr. Lambiase at Barts Central in London, in UK. The reason to present to you and to discuss with you this case is it comes from a really a nice story about this old man. And we have been struggling on how to deal with these patients that would be presented to you by Dr. Conte, and essentially is related to a syncope case. So I would like to invite Dr. Conte to start the presentation, and later on, Dr. Lambiase will briefly comment on the case, and then we would have a discussion among the three of us about the unusual presentation, but also the unusual finding of these gentlemen. Thank you very much.
So I would like to present to you a case of a patient with unexplained syncope and unexpected response to ajmaline. This is the case of a 77-year-old male with no previous cardiovascular history and no family history of sudden cardiac death, who was referred to our institution because of recurrent syncopal episodes without prodromal symptoms. The baseline 12-lead electrocardiogram of this patient showed sinus rhythm with normal heart rate, first degree atrioventricular block, and then a typical right branch block with fragmentation in lead ABL, ABF, and through V2, V4. Moreover, a J-wave of 1.5 millimeter amplitude was present in lead 3 and ABF. The cardiological workup, including bidimensional transthoracic echocardiography, 7-day electrocardiographic monitoring, as well as the neurological evaluation, did not reveal any abnormality. Moreover, this patient underwent a coronary angiogram, which was completely normal. Because of the presence of syncopal episodes, together with the presence of J waves in the inferior leads, ajmaline challenge deemed appropriate to rule out Brugada syndrome. So unexpectedly, ajmaline challenge unmasked the Brugada type 1 ECG in the inferior leads exclusively. To rule out the presence of atrioventricular conduction disease, we performed an electrophysiologic study. As you can see, the baseline HB interval was 38 milliseconds. This patient had no sinus node dysfunction, and during ajmaline infusion, no infraischian block occurred, and the HB interval increased from 38 milliseconds to 73 milliseconds. During the programmed ventricular simulation, no ventricular arrhythmias were induced. So, in the assessment of the mechanism underlying syncope in elderly patients with atrioventricular conduction disturbances and repolarization abnormalities can be challenging. Performing ajmaline challenge, in this case during an electrophysiologic study, was helpful to rule out atrioventricular conduction disease and to unmask Brugada syndrome with an uncommon phenotypic expression. Because of the presence of syncope in a patient with a drug-induced Brugada syndrome, even if ventricular arrhythmias were not induced during the electrophysiologic study, ICD implantation was discussed but refused by the patient.
Well, thank you very much, Giulio, for the presentation. This is really an unusual case for a number of reasons, and I'm very happy that Pierre accepted the opportunity to review with us the case. I think I'm really looking forward when in London you may have the same approach. So I'm talking first what you will do. Ajmaline test in a 77 years old person, where the ECG will be already an interesting or have some interesting features, but also in the end, whether you may propose an ICD as well. So, Pierre, what is your view on this?
Well, I mean, if we see an ECG that looks suspicious for Brugada, we certainly would consider an ajmaline test in the context of syncope. And what I'm going to do is have a look at the ECG features here and discuss the effects of the ajmaline and then the role of the ajmaline test. And the interesting thing for me here is also what are the mechanisms by which the ajmaline may actually change the ECG pattern. I've just highlighted a couple of features on the ECG first. So Dr. Conte already pointed out that there was some notching or fragmentation on the ECG, particularly in the ventricular leads. And then you have this J-point elevation in the inferior leads. And you can tell that you gave a good dose of ajmaline because the QRS got quite wide with the ajmaline. So you almost certainly gave a significant dose, that the ajmaline was actually infused appropriately. We would normally do a high lead ECG as well as a standard lead ECG to look for J-point elevation in the high leads, as well as the standard leads on the chest. But I dispute the fact that you actually had a typical Brugada change you certainly had a J-point elevation in the inferior leads, but you didn't have a typical Brugada pattern in lead V1. The typical Brugada pattern would be that of coved ST elevation. And this is a nice summary of the typical features. So when you give ajmaline, you need to lose the R prime at the peak of the J-point elevation. And also you normally get a coved ST segment in response to ajmaline. So if you don't see this typical type 1 response, it's not a positive ajmaline challenge test for Brugada. So what's the mechanism? Well, for J-point elevation, either in those inferior leads with the ajmaline or in the typical V1 and V2 in Brugada, this is thought to be due to the fact the epicardial action potential is notched and shortened. This comes from animal models, which causes a voltage gradient between the endocardium and the epicardium. That's called the repolarization mechanism. And indeed, with ECG imaging, when you take patients with early repolarization in the inferior leads, you do see action potentials measured as an ARI of the unipolar electrogram in the inferior leads on the ECGI map as being shorter. So there's evidence there is shortened repolarization, but that's not really the whole story. And if you take patients who've had an idiopathic VF arrest, who've got J waves on their inferior leads, as this example from Hazaguer's paper, when you epicardial map the heart in the inferior surface here highlighted, you actually see fractionated electrograms indicative of a depolarization delay, conduction delay in the epicardium. And as we highlight here, when you gave ajmaline in the inferior leads, you do get this ST elevation or J-point elevation in the inferior leads. So why is that happening with ajmaline? And this is because either the epicardial layer is electrically dissociated, and therefore the epicardial action potentials, which are shorter, allow the gradient to exist. And when you give ajmaline, you promote that gradient, you promote the delay between the epicardium and the endocardium. Or the ajmaline is making the epicardial action potential occur later, delaying conduction to the epicardium again, but dissociating the epicardium and endocardial action potential and creating the ST elevation. And it's interesting, if you look at patients with Brugada syndrome and map them epicardially, where there are J waves, you see delayed depolarization with fractionation in the inferior leads, while in patients without Brugada, it's usually more likely to be early repolarization without delayed conduction. So there are two different mechanisms. And your patient certainly has marked delayed conduction with fibrosis, which is accounting for their conduction disease. So the question is, does the ajmaline actually make a difference? Can I actually identify a patient likely to get heart block when they have conduction disease and I administer ajmaline? And the data here is very, very sparse. There was a vogue in the 1980s to give procainamide to predict conduction block. And the more recent data with ajmaline really comes from 2 or 3 small series. This is one of them of 16 patients, 9 of whom actually had bundle branch block and conduction disease on their ECG. And when ajmaline was given, it caused HV prolongation, similar to your patient, and a pacemaker was put in those patients had HV prolongation. And those patients, those limited number of patients, did actually have intermittent 2nd or 3rd degree AV block. In another series of 35 patients with bundle branch block, I'll show you here from CORE, they had 3 patients like yours with 1st degree AV block and right bundle. And those patients all had pacemakers put in, and one of them developed intermittent complete heart block. So at the moment, it would suggest, I think, when you're giving ajmaline, what you're doing, you're demonstrating there's lack of conduction reserve, but I'm not sure what the negative predictive accuracy is in these patients. And what really we need to do is a prospective study, a randomized study, maybe implanting a loop recorder or a pacemaker with minimal ventricular pacing, to see whether actually ajmaline does really predict the need for pacing in these patients.
Well, thank you very, very much.
There we go. Back to
yeah, thank you very much, Pierre. This was very, very informative and very, very nice slides, but also nice explanation for what we have observed. Giulio, any comment on Pierre's hypothesis, but also on the therapeutic suggestion? Because essentially you proposed an ICD and Pierre is more in favor of, say, ILR or eventually pacemaker, right, Pierre?
Yeah, so I'm reassured by the fact the patient didn't have a typical type 1 pattern. And the fact in this case, you know, if the ajmaline test is negative for promoting conduction block, infrahissing conduction block, that does reassure me. I put an ILR in this patient, definitely, because obviously we still don't know why they've had syncope. I think if I'd seen infrahissing conduction block with the ajmaline alone, without the Brugada pattern, I'd have to go back to the history, how convincing it is. But it's difficult to know if I would definitely have put a pacemaker in this patient. Okay. Because I'm not sure that the evidence is that convincing. I probably still would have put an ILR in first.
Okay. So, Giulio,
what did you do with the patient?
Any counter argument? I mean, to Pierre.
Oh, many thanks, Pierre, for commenting our case. Indeed, it was a really challenging case, and we were doubting on the best option, therapeutic option to offer to our patients. Indeed, as you mentioned, there are very old studies on the value of ajmaline challenging in predicting paroxysmal complete AV block in this category of patients. We did not consider pacemaker implantation in these patients because all previous studies considered a cutoff of HV prolongation above 100 milliseconds to consider a pacemaker implantation, or if the baseline HV interval doubled during ajmaline challenge. So in this case, we had a normal HB interval of 38 milliseconds, which increased to 73 milliseconds at the end of ajmaline. So we did not reach the 100 milliseconds, nor the baseline HB interval doubled during the ajmaline infusion. Another thing is that, as you mentioned, in this previous study, they reported in a few cases a complete AV block during ajmaline challenge. This did not occur in our patient during the pharmacological test. Regarding the explanation for the electrocardiographic abnormalities, we know that up to 5% of Brugada syndrome patients can present with abnormalities, so J waves in the inferior leads only, or infralateral leads, either spontaneously or during provoked by sodium channel blocker test. So our diagnosis was based on Brugada syndrome was based on this finding. So we finally considered an ICD implantation in this patient, because based on a very recent pooled analysis by Schubreck published in Circulation in 2016, this category of patients with Brugada syndrome presenting with syncope and with no ventricular arrhythmias induced by an electrophysiologic by programmed ventricular stimulation have 1.3% per year of spontaneous ventricular arrhythmias occurrence. So this was a really challenging decision. Therefore, we discussed all the risk and benefits of implanting an ICD with the patient, and after the discussion, the patient refused the ICD implantation.
Yeah, I mean, I would strongly dispute this patient has Brugada syndrome. The diagnosis of Brugada is not made on the inferior lead pattern. It's made on the chest lead pattern V1 to V3, as you know. So I agree there is a suggestion of a Brugada-like pattern with the ajmaline and the inferior leads. And we've shown, thanks to you working with you, that when we take a large series of patients for primary prevention with a Brugada pattern ECG, and they have early repolarization, there is an increased risk of ventricular arrhythmia. So it is a risk marker, but it's not in itself a diagnostic sign of Brugada in the inferior leads. That's a really important point to make. So your patient was right not to have an ICD because he doesn't have Brugada syndrome. But the mechanism, I think, is probably very similar when you gave the ajmaline, why you have that J-point elevation with the ajmaline.
Yeah.
So, Pierre, the other question is, would you conduct a genetic testing in these patients, or you say, and on the other hand, say, well, he is a 77 years old gentleman, does not make really major difference at all?
Yeah. No, well, that just goes back again to the history. So in his case, you know, he's got conduction disease. The first thing is to identify if there's a family history. Is there anyone else in the family that has syncope, premature sudden death, premature pacemaker implantation? Because it's conceivable he has a sodium channel mutation, and that could have caused the conduction disease. In this type of patient, you did an echo, and we're increasingly doing MRI scans in these patients who have conduction disease, mainly to just check they don't have sarcoid if they don't have a family history. But you might find in this patient there's posterior lateral wall scar, and if there was a history of premature pacemaker implantation, you think about a lamin mutation, which would significantly change how you manage the patient. So the bottom line is history and family history is very important. And in this age group, I wouldn't routinely do a genetic test unless I had a good family history to suggest there was a reason to do so, that there was something else going on in the family.
So, Giulio, the question to you is, would you still propose an ICD now to the patients or not?
No, so the ICD implantation was just considered based on the doubtful findings in these patients. It was not a straightforward recommendation, of course. We just discussed with the patient the abnormalities found during the diagnostic workup.
Okay, so the other point is, Pierre, is about this gentleman had repeated syncopal episodes.
Yeah.
So now, again, we don't have, of course, we don't have an ECG during the syncope, so we don't know exactly the course. Again, what you suggest about the ILR, or you say, well, I will really go straight forward to a pacemaker eventually, because the likelihood is pretty high that you may have NAV conduction disturbance or whatever it is. So the question is, really, would really make sense an ILR in this case, or to go straight to a pacemaker implantation?
I mean, that's a really good question. I think it boils down to the history, really, of the syncope. So if they're out of the blue syncopal episodes, and there's no other, they sound highly likely to be arrhythmogenic, it's not unreasonable to put a pacemaker in and avoid the ILR. I think if there's if it's not clear cut that these are syncopal episodes, or they're positional or related to particular circumstances, then I would put an ILR in first. But given the fact there is conduction disease, it's not unreasonable to put in what I would call a guardian angel pacemaker. Okay. Then at least you're covering the risk of syncope causing injury. And we know very well, if patients have had injury with syncope, it's very likely that there is an arrhythmogenic cause if the heart's structurally normal, no valvular disease or anything. So I think it's down to the history. And I mean, in a way, reassuringly, you gave him ajmaline and he didn't get AV block. So actually, he's probably got quite good resistance, but we don't know how what the true negative predictive accuracy of that test is.
Okay. Giulio, any remark or any comment on that?
No, I have no further comments.
Okay, then I think we can close here. Thank you very much to you, Giulio, for this very nice and challenging case. It really was for us, and for you was a difficult decision. Thank you, Pierre, for helping us in elucidating the possible mechanism, but also to provide us with, probably an alternative solution and with alternative therapeutic path for this old gentleman with recurrent syncope. Thank you very much to both of you, and enjoy the afternoon. Bye-bye.
Thank you. Bye.